Good afternoon. It's an honor to be here. Happy anniversary to NHRI, 30th anniversary. In addition to health policy and work, I also practice pediatrics. I do teaching clinic about once a week. And in Taiwan, I actually have a startup using technology to help the elderly. So this topic is very close to my heart. So in thinking about health and technology to connect the world, so what's in common about health and technology is that they are both highly dependent on trust. So when you're getting data from people or you're trying to do something to people, you have to have trust. So when we think about health and technology, we have to think about design principles. What are the design principles when you want to implement or use technology in helping to promote health? And some of them are, for example, closing gaps in access, fostering trust, and improving outcomes. We also want to build equity, efficiency, and resilience in health systems. And so with that in mind, I think we could then begin to think about the use of technology in improving health. So first, health equity. So it cannot be a second thought. It has to be access by design, equity by design, the care that speaks your world. So let me give you some example. When we design health systems for the underserved populations or rural areas, we have to think about, for example, a gentleman from police was mentioning this morning, well, how do you deliver rural health using telehealth? Some places have very low bandwidth, like 2G. Not every place has 5G, right? So when we took students to Guatemala, we have to use a specific building to set up the telehealth program, and that's where there's internet and Wi-Fi. Some places have old devices, so you try to deliver it to people with old devices, and sometimes offline. You have to think about how to design those equipments and programs. Language and culture are very, very important. You have to think about the workflows and using the right language. And also, because of health literacy, for example, the health promoters in Guatemala has a 4th grade education. So you have to basically create something that they will understand with the right literacy level. Accessibility. You have to build to WCAG 2.1 AA standards for people with disabilities so they could use it. Whether it's voice, audio, captions, keyboard accessibility, you have to be able to resize and also integrate assistive technology. I think Dr. Christakis talked about that yesterday, about integrating that into Special Olympics. Agency and safety. People want you to consent them. They want you to know how you're going to use their data. And there needs to be human override when necessary and an audit trail so people don't abuse the system. And if you want to implement it into a patient population, it has to be zero cost. Somebody in the health system should recognize the value and pay for it and not have people pay for it. The continuity is also very important. If you're going to have a citizen-facing record that travels with the person. So in Taiwan, technology has been used actually during the COVID-19 pandemic to enhance equity. So during that time, there was a shortage of masks, and there was a panic trying to get the masks. So what the government did was using the NHI card to do name-based rationing of the masks. And there's a per person limit per week. If your birthday is even number at the end or odd number at the end, then you take turns to go and pick up your masks. And it's very cheaply priced. It's like 10 NTs. It's very cheaply priced for a whole bunch of them. And government also at the end publish maps for where you could get masks close to where you live. And so this created an equity effect where there are clear rules, there's open data, it's predictable access, and they lead to short lines. Okay. Now, many people are very nervous about AI for human-centered care. Well, I think they're going to augment clinicians and caretakers while we have to pay attention on how to protect empathy. Okay. So AI in the value chain of care. So first of all, we create the foundational models from data. So the data cannot be biased. Then you build models on top of that. Then you build applications on top of the models. And then you go from there. So you have to start with the right data set that is not biased. That has to be representative. Like I said, it has to be consented, high quality data. The models has to test against independent data sets, not the one you created. You have to monitor the drift and bias, ship, meaning implement the app or whatever you're trying to do with a change plan, so safety updates could be done. And then, of course, you have to look at the workflow and how to implement that, embed it, either in, if you want to embed it in electronic medical records or something else. But the doctor or the clinician has to have the final say in overriding. We have to be able to track outcomes, whether it's a diagnostic yield, time to result, safety events, quality gaps, and so forth. AI has been implemented in a number of settings, and I'll give you a few examples. For example, in the UK, this program called MIA has been used for breast cancer screening images, and it has led to more detection of cancers. In areas where there are shortages of radiologists to read them on time, you could use that. It will sort of reduce the limbo for patients waiting for the callback. Waiting time is anxiety time, so you want to give them at least the first cut of it. And then the doctors could spend more time explaining things to the patient. Okay. Again, this you could do at first level or as a double check. Stroke imaging also, some has been used for accelerate CT interpretations. And sometimes in stroke, time is very important. Time to treatment is very important. So if you have very high index of suspicion, you should move somebody to the surgical room. And then sepsis as well. Sepsis, often, right now, there's programs that could allow 12 to 24-hour early detection of risks. And people with high risk of crashing, you should get on it. Connected health. I think many of you are wearing either a Fitbit or Apple Watch or Garmin. And it allows the type of monitoring and also personalized monitoring. So you know how your body is doing, and it sends alerts to you, or you could actually send alerts to other people if you want to. With the goal of early intervention, fewer crises, personalization at scale. So it's personalization at scale. It's like an oxymoron. I mean, you could actually do this. And system readiness. When you have large disasters, you could actually use this as well. This also has been implemented in Taiwan. In Taitung, for example, telehealth initiatives have served more than 18,000 residents. And you could schedule telehealth clinics with connected devices in special kiosks. So they say in community health centers that has good internet, that has the right type of imaging. You know, you could do face-to-face. Sometimes you could look at the retina, I think one previous example. And you could avoid exhaustive travel. And this is particularly useful for medication reviews, like, you know, are you going to dose the medication up or down? You don't need to travel to the hospital, or just regular monitoring or follow-up. For first visits, you probably still need to go see your provider, your doctor. The device could also provide trends over time. So hypertension, you know, if you have records of different blood pressure measurements on the same machine, you could track it over time to see if the person needs to have more intervention. In England, NHS has implemented virtual wards. So this is sort of hospital at home. And the consultant led acute service that substitutes for an inpatient bed. So you're actually at home. And then with the multidisciplinary team rounds for diagnostics, medication optimization, and technology-enabled remote monitoring. So who do they apply this for? They will admit people from home, at home, who feel unwell, or if they were in a same-day emergency or emergency room, to avoid admission to the physical hospital. Or they would do this when they transfer patients home earlier and still require monitoring. So this now is 22,000 step-up admissions across 29 sites, and on average is one avoided non-elective admission per 2.5 virtual ward admissions. The national capacity is 20 virtual ward beds per 100,000 GP registered people. So the outcomes are comparable or better than inpatient care for mortality or readmission. So these are examples. I'm sure there are more. Global informatics and governance. So basically, you know, you want to share data, but you also want to share trust. Okay, so in order to share trust, you have to have governance. And when you have the digital adaptation kits where people could basically use those kits to upload their data and have health management information systems, that allows a health system to use the data to track. It becomes very useful. In the EU, there's My Health, which is a cross-border e-prescription, e-dispensation patient summary service that's been adapted by 15 member states, and they're already exchanging data. More will join in 2025. Globally, DHIS and the WHO SMART guidelines using the digital adaptation kits is the largest HMIS used in 80 countries. And in Taiwan, we just heard yesterday from the Global Health Forum that Taiwan has now health information standardization platforms that includes the health data space using HLA 7 FHIR standards, which allows you to use mobile data as well. And also, they have the rule space where you could monitor quality using clinical quality language, and the health apps are going to be available. In the US, we're very conservative. We're still using federated learning because people don't want to share data. They only want to share the model. And so you could do that. And so you could create a model in site one and then share the model and test it in other sites and create a next version of the model. AR, VR in medical education. For areas without sort of a lot of medical educator and resources, AI and AR, VR could be used to spread knowledge and practice safely before you get to the patients. So you could standardize the scenarios and the instrument for every learner and measure their competence level. So you know if they're doing something wrong because you are actually also measuring it at the same time. Off-the-shelf headsets and haptics allow you to practice. And this is more and more common. And so in Taiwan, it's also been used to teach anatomy in a VR classroom. At Kaiser Permanente as well, using augmented reality on some of the teaching there. The students could have a walkthrough of the different sections of the body, whichever cut you want, and so forth. Okay. You could also use it to practice before surgery, and we've done it at Stanford using CT scans, and residents will practice doing surgery, navigating with that person's anatomy. You could do it with eye surgery, train a lot of people to do cataract surgery. Precision medicine is another area of technology that Taiwan has now the Precision Medicine Initiative, very similar to the UK Biobank. A lot of applications in the future to merge medical data with genomic data, with proteomic data, to come up with the right care, the right genes at the right time. You could also use it for behavior nudging. Singapore has the Healthy 365 app paired with free wearables, and you could actually monitor if you're exercising and doing, you could also team up and to make sure you exercise. NHS also has similar things, and they have different levels, different tiers. Finally, planetary health is very important. You could use technology to monitor PM 2.5 for pollution, or you could use it to measure heat to prevent heat exhaustion. So these are sort of a quick overview of how technology could be used to improve health. And thank you again for your attention.